Okay, sounds good. All right, thanks, guys. All right, Allison, take it away.
All right, everybody. Hi, so my name's Allison Rollins. I'm one of the residents here at the University of Pittsburgh with Dr. Basura. And today I've chosen the somewhat esoteric, but also very wide-ranging topic of head and neck paragangliomas. And so I'm going to try and do like a quick overview of our current understandings and management of these types of tumors, and then go into a few cases. So paragangliomas, what are they? They are tumors arising from the neural crest. They are specifically cell clusters that facilitate baroreceptive and chemoreceptive functions in the cardiovascular system. The most common baroreceptor that we think about is the carotid body, but they can be all sorts of different ganglia throughout the body. Most frequently, they're seen in the adrenal system, but there's quite a few that are found in the head and neck. At least one quote said about 90% are in the adrenal glands. Those would be known as our pheochromocytomas. And then the remaining 10% are usually found in the various ganglia of the head and neck region. They can be classified as functional or non-functional, meaning that they secrete catecholamines and may present as secondary hypertension. So typically that is found in pheochromocytomas, but can be found in paragangliomas and other areas of the bodies. And then they're typically either sporadic or as part of hereditary syndromes. There's also some familial paraganglioma syndromes, which have been elucidated in the last few years as well. So distribution of paraganglioma, as I said, there's a few in the head and neck region specifically that I'll be focusing on today. So there's the branchiometric paraganglia, which is found along vessels and cranial nerves in the head and neck region. We kind of have three specific areas of those in our head and neck system. So the jugulotemporal, which is coming from the second brachial arch, and these are ones we typically see in or around the ear and in the skull base. And then the carotid, which is typically at the bifurcation in the head and neck region, and that's coming from the third brachial arch. And then there's another group of paraganglia in the head and neck, which are the vagal paraganglia. And of note, these do not have any association with branchial pouches or embryologic origin and can show up in kind of varying places because of that. And then here's just a good illustration of all the different areas of paraganglia in the head and neck region and where these tumors might show up. So risk factors in epidemiology, these are very, very rare tumors. They have a 1 in 300,000 annual incidence when they're not occurring in the adrenal system. Of those tumors, 80% are carotid body tumors, and 5% are vagal paragangliomas, and then the remaining 15 are either jugulotemporal or paragangliomas in other locations. Interestingly, if someone has a carotid body tumor, 20% of those folks may have another carotid body tumor. So it's important to assess for other paragangliomas and other areas whenever you have a paraganglioma you find in the head and neck region. And again, overall, 22% have multiple paragangliomas, and in 10% of sporadic cases, there's more than one. So a good thing to look for is other paragangliomas whenever you find one. Risk factors at this point, there's some risk factors relating to genetics, which we'll talk about later with specific gene mutations. And then is some theory that living at high altitudes can either accelerate the growth of paragangliomas and or potentially initiate growth, although the mechanism for that has not been fully elucidated. Some of the individual familial syndromes and specific kinds of paraganglioma tumors have associations with gender and age. However, it's not really clear or elucidated at this point. So here's some of the hereditary syndromes associated specifically with familial paraganglioma. So on chromosome 11, there are 3 loci that are associated with succinate dehydrogenase, which, if you remember back from biochemistry, is like part of our Krebs cycle. Unfortunately, we don't know exactly why succinate dehydrogenase, what part of the metabolism leads to the development of these vascular tumors. But we do know that this is a contributing factor. And there's several different loci here, which are associated with various predispositions. So PL4 is associated with malignant paragangliomas. PGL1 and PGL4 are associated with a syndrome which has both head and neck paragangliomas and pheochromocytomas. And then tumors that develop at a younger age are more likely to be associated with this familial paraganglioma syndrome. And in some of these mutations, they have found that there's an effect of, if your grandpa had one at age 60, and then he has a son who has a paraganglioma syndrome as well, then the penetrance is higher. So you may have kind of an earlier and earlier presentation in some of these familial paraganglioma syndromes. And so it's important, if you suspect that there may be a hereditary or familial involvement, to talk to them about getting their family screened, whether that be through genetic testing or imaging, or just frequent surveillance, depending on what resources are available. Then there's the other tumor syndromes here, which you might see a paraganglioma with neurofibromatosis type 1, MEN type 2, and von Hippel-Lindau, all predisposed to paragangliomas in the head and neck region. Most of these, at least in our practice setting, the paraganglioma is not necessarily the first presentation that would suggest that you had one of these syndromes, but certainly important to rule out these other tumor syndromes. So the clinical presentation of these are often cranial neuropathies or compressive symptoms, and that depends entirely on the size of the tumor. They could be abutting cranial nerves, so you can have swallowing or speech difficulties with vagal paragangliomas. You can have high blood pressure or compressive symptoms, or hypotension with the carotid body associated tumors. And most frequently in the ear, in the jugulotympanic region, you may have pulsatile tinnitus or perhaps bleeding if you have those kinds of paraganglioma. And then additionally, if you have a secreting tumor, so one that secretes catecholamines, you may also have hypertension, tachycardia, sweating, and nervousness. There's a couple of classification systems if you're looking at radiology of these types of tumors. The Shamblin classification system is used for carotid body tumors, which essentially is size here and involvement of the vasculature. So the important differentiation here is that type 3 involves the vessels themselves, like the adventitia of the carotid body, and type 3B is any size but involving the vessel wall. So these tumors are considered extremely high risk for operations and having cranial nerve deficits or potentially vascular complications if you attempt to operate on these without prior pre-planning. And then the other classification is for the jugulotympanic paragangliomas. This is the fish classification. I did not have such a good picture for these, but it essentially delineates where the tumor is and how much of the structures are involved. So class A is a glomus tympanicum, meaning the paraganglioma is confined to the middle ear, and then the tympanomastoid area, and then the class C starts to erode the infralabyrinthine component of the temporal bone. So imaging for these tumors, most likely first scan to get would be a CT scan with contrast. You can also consider a CT angiogram, as these are highly vascular. They're going to light up with contrast going through them and give you a good understanding of the extent and the area of the tumor. It will also allow you to kind of differentiate, especially if in the neck, whether this is a carotid body tumor or a vagal tumor, depending on how the vessels splay and or how they're displaced. MRIs with gadolinium contrast are also used. They're considered a salt and pepper appearance on T2, again, because of the way the contrast moves through them. And they're most useful for surveillance in folks you're going to be watching for a long time and not operating on. And they also help confirm diagnosis of paraganglioma, or fully understand the vascular extent for especially paragangliomas that might be into the skull base. So treatment for these is primarily surgical resection, although there's been some role for radiation therapy in smaller tumors. And as we learn more and more about these, a lot of them are managed with observations, especially for elderly patients with lots of comorbidities, and those that don't have debilitating cranial neuropathies from these tumors. Additionally, if you have baseline poor swallowing with a vagal tumor or severe cranial neuropathy, you may elect not to operate, given the risk of cranial neuropathies worsening, especially in large or kind of higher class Chamblin tumors. So with all of that information, we'll go into our first case here. So this is a 70-year-old female with a large neck mass here, and this is the mass here, and then these are the internal and external carotid there. And so the question is, what kind of paraganglioma is this to begin with? And then any thoughts?
So on the image that you've shared, there is no splaying of the great vessels, so I would think it's unlikely to be a carotid body tumor, because a carotid body tumor should push the two vessels apart. So top on my list could be maybe a glomus begale.
Yes, yep, exactly right. Yeah, so this should be a vagal paraganglioma, because there's no splaying of these vessels, and then it also displaces these arteries anteriorly, which you can't necessarily see in this image here. And then the internal jugular vein will go posterior laterally with vagal tumors most commonly. So that is how you can differentiate this one from a carotid body tumor. So what should we do next? What is any further history that we need?
Hey, Allison, sorry to interrupt you. Sorry to interrupt you. Can I ask a quick question?
Yeah.
What might this patient also show on clinical exam? Other things you might look for on this particular patient, other than a large neck mass? Are there other specific findings that might lend you to identify this diagnosis potentially?
Yeah, so I think I was gonna get into that after the
Oh,
fact,
you
but
were.
yes.
Oh, sorry. Sorry, didn't mean it.
No,
Okay,
no.
sorry, didn't mean to steal your thunder. I'll stop talking. Okay.
Oh, I was gonna ask, is there further history that we want to know about this patient and this neck
Perfect.
mass?
Got it. Thanks. Sorry.
So duration of the mass is important, how long the mass has been there. Glomus tumors are usually slow.
Mhm.
So we want to know over what period we've had the mass for. We want to take history encompassing all our lower cranial nerves. So we want to know about voice, swallowing, any choking, any hoarseness of voice, or change in voice, or is it fatigability, breathy voice. So there we are looking for functions of the vagus nerve, but also we want to know about tell me the image again. Just show the image again.
Sorry, what was that?
Just show the image again.
Yeah.
Yes, so it's extending a bit to the skull base, so I would want to know about ear symptoms, tinnitus, hearing, any ear discharge or otalgia, any headaches. And then we'll also ask about things like chewing, to look out for palsy, spatial palsy, hypoglossal palsy, if they get food trapped in their mouth, if they have trouble turning food in their mouth, issues with chewing, jaw pain. We're trying to ascertain the extent of the tumor.
Yeah, excellent. So in this case, this is one of the only cases I made up. So I don't know this man's true symptoms. However, I think that in this case, it would be likely that they would present with some component of dysphagia and or odynophagia, especially given the location of this tumor kind of in the parapharyngeal and like pharyngeal space here. And so I think in this case, it's likely that he had some hoarseness and dysphagia on presentation at minimum. I do think that assessing the extent of the skull base here is important. I'm not sure if he had ear findings in this case, but I do think it would be very, very important to obtain an ear exam as well. And then in any symptoms of hypertension would also be on my question list, especially with a tumor this size. We'd want to assess and make sure that there's no other problems, no other kind of, postural hypertension and tachycardia symptoms he's having, because this tumor may not be secreting, but he may have one elsewhere that is. Was there other things you would have included, Dr. Basura, other than what has already been said?
Yeah, I guess.
For me,
Sorry, go ahead.
Oh, go ahead.
So for patients who present with glomus vagale, the things that pop up in your mind is one, the likelihood that it's familial, and two, the likelihood that he could be having autonomic symptoms. So you want to look for autonomic symptoms and not just tachycardia and hypertension, but symptoms of anxiety, increased sweating, palpitations, increased GI motility. So some of these patients could be having hot flashes and extreme loss of weight, and some of them also have some diarrhea kind of symptoms. So it's important to have that, and also to ask for family history, because again, most of these patients tend to, vagale has a stronger family history component.
Yeah, that's good.
Excellent.
I was going to ask too, if you didn't have the imaging available to you and you just had somebody that comes in with a large palpable neck mass in that area.
Mhm.
What other things might you be thinking about, or other physical findings would you be looking for? This is kind of a read my mind sort of thing, but big neck mass, maybe in the gutter of the neck. You don't have imaging.
Mhm.
Oh, wow, that's a big tumor. I want to think about some other clinical findings that might help me, you know, rule out some other possible etiologies. What do you think?
So,
So,
examine the mass and, sorry, Alison.
oh, go
So
ahead, go ahead. No, excellent.
Examine the mass, palpate the mass and feel for mobility. Is it fixed? Because you're differentiating it from other neck masses or tumors. So if it's a large lymph node and it's not fixed, it would feel different from this mass. Feel for the consistency. Is it a firm mass? Is it a fluctuant mass? And then it's also important to listen for bruise over the area, because for carotid body and carotid aneurysms would have a bruit when you put your stethoscope over the mass, which wouldn't be present for glomus vagale. You just have the carotid pulsations, but no additional sounds after that.
And maybe just to add a little bit, but in the palpation, you want to palpate in the vertical and horizontal direction to check as to whether it's adhered, or to check on the extent in terms of in relation to the blood vessels. So that if it is not, if it is mobile in the vertical but not mobile in the horizontal plane, then you think more of it being related to the vasculature as compared to a free mass that is not adhered to the vasculature.
what about an eye
Yeah.
exam? What about an eye exam? You got a big neck mass. You're not sure. You don't have imaging. Big neck mass. I'm trying to steer you guys into another particular. What about an eye exam? What might you find on someone's
So
eye
on the
exam?
eye exam, you have to look out for Horner syndrome. So
Ah,
look for look
aha,
for
aha. Okay. Why, what's a Horner syndrome, and what might that be indicating?
So a Horner syndrome is a deficiency in the sympathetic innervation of the eye. And the sympathetic innervation of the eye, it can occur at different levels. The sympathetics of the eye are in three orders. You have the first order neurons, second order, and third order neurons. So the first order neurons come from the hypothalamus down to the cervical vertebra. In the, I've forgotten where they end, the first order ends. And then we have the second order neuron that moves from, I think, T1 to C. This is coming from and then the third order neuron comes back along the cervical, along the carotid from to join the carotid plexus. It comes into the cavernous sinus and joins the abducens nerve as it comes back to the eye. And primarily, it will give three functions. It will give sympathetic innervation to the vessels of the face. It gives innervation to the long ciliary muscle, which is important for pupil dilation. And then it also gives innervation to the levator palpebrae muscle. So in a patient that has Horner syndrome, you're going to have a dry half of the face because they're not sweating. You'll have a small pupil because the parasympathetic are acting unmatched, and then you have a partial ptosis.
Nice.
So you
That's
look
good.
out for
What do you call that unopposed parasympathetic constrictor of the pupil? What's that called?
meiosis.
Yeah. What do you call it when it's dilated? What's that called?
Hydriasis.
Yeah, there you go. Nice. And then ptosis is the levator, and then you talked about anhidrosis, right? So what would be the most common pathology of someone who has a Horner syndrome? What is the tumor that you might be thinking of?
A carotid body tumor.
Hmm. It's affecting the sympathetic chain typically, right? So do they usually start from that area? I mean, what would be something that could affect the sympathetic chain that would give you a Horner's?
A vagal schwannoma.
A schwannoma, but typically of the sympathetic chain, right? Right? Yeah. So just think about that in your differential, right? So someone who's got a big neck mass in that area, right? You want to forget about that. Make sure you do a good cranial nerve exam. Sorry, I didn't mean to completely take over the talk here, but that's just important in the differential, right?
Yeah, 100%. Actually, when I was looking for cases for this, I thought I had one and it was a vagal schwannoma instead of a vagal paraganglioma. So I had to not include it because not the purpose of this talk, but
perfect.
they also will not enhance as much on scans if you have a schwannoma.
Be a bit more homogeneous typically, right? They
Correct.
don't have like they don't have the classic flow voids, so you don't see that salt and pepper sort of look. It's a bit more homogeneous, solid tumor in the gutter of the neck. Yeah. Okay. All right.
Yeah.
I'll stop talking.
Okay. Would you get catecholamines and or other laboratory tests on this patient?
Yes, we would. Yes, we would.
Yeah.
Catecholamines. Serum.
Yeah. So typically here we order serum metanephrines, and then I have also seen endocrinology get like just a catecholamines as well. I'm not, super familiar with when we should get both, but typically in our clinic, if we have a paraganglioma, we get serum metanephrines first. And then if endocrinology is concerned about pheochromocytoma, they would get catecholamines later, meaning like epinephrine and norepinephrine levels. In this case, let's see, we talked about imaging. Most frequently, unless we're planning to operate on this, I probably wouldn't get more imaging than the CT scan that we already have here. And then you can consider endocrinology consults in a lot of these patients, although at least here in our clinic, it's variable whether we do that. And then most frequently, we also try and get genetic testing on these folks when it's available to us. And I think particularly if this patient was much younger, we definitely want to have a higher suspicion for looking for other paragangliomas and familial syndromes given the age of presentation.
In the imaging, you also want to image, you want to do abdominal imaging because you're concerned about them having an ectopic paraganglioma, mainly at the adrenals. So you want to ask for abdominal. Is that ultrasound or mainly CT scan? So you have to image the abdomen.
Yeah. So I've seen us get a CT scan with contrast to look for those. Is usually the first test that I see. Okay. Yeah. So in this case, I think it would also be important to probably scope the patient if they presented into your clinic and you had that available to you, especially if they're presenting with dysphagia symptoms and hoarse voice. In the absence of having a scan as well, it'd be important to make sure that this is not some sort of, other tumor that is involving the parapharyngeal space. I don't know why that did that. Hang on one second. Okay, so case number 2, this is, well, This is not the picture of this patient, but maybe something along these lines. We have a 39-year-old female who's G1P1. She's at 37 weeks and 1 day, and she's pregnant. And she comes in with a left neck mass. The ENT resident is consulted because they found an ultrasound here, and it's in the region of the carotid space, and they're concerned about this mass and the fact that this woman is pregnant. What other things do you want to know about the patient?
Well, I want to know how long it's been there for. Like, is it steadily growing? Is this something that's been there for years? Does it fluctuate in size? Is it painful? I also, just because of where it is, I want to know about any ear symptoms, so all fullness, pulsatile tinnitus, hearing loss, would be my another option. And then she's pregnant. Does she have any other sort of comorbidities with her, like GPH or those kind of things? Because about that. And then she probably wouldn't have any sort of. I could ask her about constitutional symptoms, but I mean she's pregnant, so she probably have that. And then I would also just ask her sort of about generally how she's feeling, and if she does have any, like you say, these patients sometimes can have anxiety or hypertension. And then I want to know about any family history of masses, if she's had any family history of that. And then I'll probably go on to an examination. And I'll feel how it feels. Is it firm? Is it fluctuant? Is it mobile? Is it stuck down onto the underlying tissue? I don't see any skin changes on. I don't think there's any skin changes or orange peel effect. I also want to feel for other nodes in the neck, and if she could have any other spots on the skin or anything like that. I want to look at here and see what the canal looks like, just in case this is actually going into the canal. I want to look at the eardrums and pulsatile. Is there any fusion, anything like that? The ear exam. I want to do a cranial nerve exam, check for Warner's syndrome, check her eyes, check her facial nerve fallout, look at the palate, see the soft palate's deviated, check for glossal nerve function. So ask her the history, if she had any voice changes from dysphagia, and probably want to scope her postnasal space and go down into her larynx to see what her vocal cord movement is like. And then obviously I have a listen over here, is listen for Brui, that's what I would do for now.
Excellent. That was good. Very complete. So in the real patient, I would say the mass is not actually as big, but we didn't have a real picture of them. So not as obvious, but this patient said essentially she started feeling a lump in her throat a few weeks ago. But maybe it had been there for a while. It had been getting bigger, and she just felt it sometimes when she was swallowing or sometimes when she was, feeling her neck. She didn't think that it was pulsatile, didn't have any other neck masses. Her ear exam was normal. She didn't have any dysphagia symptoms, no obvious cranial nerve deficits. She did have a scope which showed like normal functioning larynx and vocal cords, and no dysphagia symptoms. This patient was admitted essentially to work this up. And so they did get a scan on her, which I have here. So this is her tumor. So a little bit less obvious than in the picture. But it was noted to be a Chamblin 2 carotid body tumor. So meaning it was encasing the carotid body in this case. Given that she's pregnant, is there any other things that you'd want to think about? So a small tumor, relatively asymptomatic, other than that she can feel it in her neck. She does have, did have hypertension of pregnancy, or that's what they thought it was, hypertension, and she had some gestational diabetes as well. And they essentially decided this is a carotid body tumor. What should we do in terms of, you know, preparing for her imminent delivery, if anything at all?
Well, I think she would obviously have to deliver in a high care setting. I don't think she could, you know, go to an MOU and deliver there. If she has GPH, concern is that she eclamptic. So you definitely want to put in a tertiary setting and monitor that. And then you might want to think about maybe not necessarily waiting, depending on how she feels, but I mean, I would want to deliver her a little bit earlier and not wait till she goes naturally into birth. So you might want to think about, you know, chatting to her about that. But it also depends on if she's got protein in her urine, if she, you know, what her placenta looks like on her ultrasound. You know, because normally the GPH patients, you want to kind of deliver them at the earliest, safest for the baby, but also at the earliest for the mother, so that they don't develop all the complications that comes from that. So my first priority is if it's small, it's not really symptomatic, she can kind of just feel it. I probably want to deliver her first before offering any surgery or any treatments if it's asymptomatic.
Yeah, excellent. So in this case, because we're a big tertiary center here, she got all the consults. She got an endocrine consult, an ENT consult. Anesthesia also saw her in preparation for potentially complicated birth. The endocrine and the ENT teams decided in this case that we should get the serum metanephrines and catecholamines and try and get those results back before her birth. And that the OB-GYN and anesthesia colleagues would try and induce her at 39 weeks and then observe her to make sure that there was no hypertensive or preeclamptic complications. Unfortunately, a few weeks later, when all of this was planned to happen, none of her serum metanephrines or catecholamines were back. However, she had no issues with her hypertension and delivered successfully. And then a few months later, she had seen our office again for planned resection of this tumor and underwent this, but unfortunately was found to have further involvement of the adventitia. So her case was canceled intraoperatively. However, in these patients with the carotid body tumor, if you're planning on going after them, it's important to consider, the vascularity of these tumors. How much is it involving the carotid? And if it is involving the carotid, are you going to need either preoperative selective embolization if you have that available to you, and or carotid body reconstruction? Some would argue in a patient of this age to just observe and go from there, which I think is probably what will happen with her going forward at this point, given the risk and the possible need for carotid body reconstruction.
I have a question.
Yeah.
So when you choose to take the patient for for surgery, is there a role for doing a pre-operative DSA? Just something to look at the carotid vasculature and assess the, for collateral blood supply in case of, because of the risk of the patients getting a stroke, especially for the carotid.
You said carotid body, like, are you talking about
angio,
balloon dilation
no, DSA, angiograms, just doing angiograms, look at the carotids all the way to the brain and look at the circulation, collateral circulation, to out the risk of the patient developing a stroke or something. Do you routinely do that, or do you just do on a case-by-case basis?
Yeah, so I think in that particular case, she did not get that done. But in the literature, and particularly folks that do a lot more paraganglioma resections, the recommendation for these is to always get preoperative angiography if you have it, at minimum like a CTA of the neck. And then in high-risk tumors where you think that it's large or possibly involving the carotids, the adventitia, if any of those is part of your suspicion, then they actually recommend getting angiography and potential like balloon occlusion testing of the operated side to see if there's appropriate contralateral circulation, because if the other side is completely stenosed, you wouldn't want to offer those patients surgery because they may or may not tolerate the lack of blood flow even for the short period of reconstruction in the surgical case. So yes, I don't know why it wasn't done in this case specifically. I wasn't involved in her surgical decision-making process, but that is the recommendation at more high-volume paraganglioma centers especially. Okay. Case number 3 is one that I saw with Dr. Becerra. So I have a 50-year-old female who comes in with pulsatile tinnitus. She has an ear exam somewhat similar to this, and this is her audiogram. Any other questions you'd like to ask her?
So I see that she's got pulsatile tinnitus. So on history, I would ask her, obviously, if she's got hearing loss associated with that, any pain or fullness of her ears, yeah, I'll probably start there. And also ask her how long it's been there for, and ask her, with regards to the pulsatile tinnitus, I would ask her just as part of it if, moving her neck or compressing her neck decreases the tinnitus or not. And from there, obviously do a otoscopy exam. And here, it's so this is the endoscopic view of a right ear. And I can see there's an obvious, very red plush mass in the middle ear, and the eardrum looks like it's bulging. I don't see, there's a light reflex and all of that. And then I would probably want to do a pneumatic otoscopy and see if there's a blush, blanching, like a little brown sign there. But I would not touch that. I would say imaging, because a closed tumor would be something I would be worried about. Yeah.
Excellent. Yeah. So we did a pneumatic otoscopy in this patient, and this mass blanches with pneumatic otoscopy, which is known as brown sign. And can be associated with glomus tympanicum. In terms of her other symptoms, I think she had some fullness and some muffled hearing loss on that side, obviously, as shown by her audiogram. She had no other neck masses, no other cranial nerve deficits. I'm not sure, I don't remember if we pressed on the neck, but if we did press on the neck, it didn't have much difference in her pulsal tinnitus. I don't recall that. It was also important to note unilateral pulsatile tinnitus only, localizing to that right side. She didn't have any symptoms of bleeding from the ear, no other vascular anomalies, no other history of vascular tumors in her family that she was aware of. And then no symptoms of hypertension in this woman, no like anxiety, sweating, tachycardia symptoms in the past at all. And then I tried to find some otoscopy of other things that you might see in the ear that are not a glomus tympanicum. So we have here, this is a aberrant carotid artery actually in the ear or in the middle ear space. And then this more kind of bluish mass here is a high riding jugular bulb. And actually this is from a case report where it's sort of eroding into the floor of the middle ear. So some other potential vascular things to look out for in the middle ear. And then in terms of this patient, what did we do next for her? I think we've kind of talked about this already, but in her case, we did the pneumatic otoscopy. We sent out serum metanephrines. We referred her to genetic testing. She had gotten a CT neck with contrast, a CT abdomen, and a CT chest to look for paragangliomas in other locations. All of those were negative for vascular tumors that I recall seeing. She did have a small elevation in her metanephrines. And initially discussed with patients, and she wanted to undergo surgery for this because the pulsatile tinnitus was bothersome to her. But I think once the case actually came up, she decided to cancel. So, yeah, these are some of my references. I do have another case, but I didn't have time to include all of it. Similarly, these ear paragangliomas can present as bleeding from the ear. We had another patient who also had I believe it was a glomus jugulare that was presented as a ear mass that was bleeding in the ED, and that was her first presentation, which Dr. Becerra also took care of. So another thing to look out for would be a mass in the ear canal specifically with these, and then have a high suspicion if it appears vascular, and maybe not biopsy it, especially if you're worried about bleeding. And that's it.
I have questions not for you, Allison, for Dr. Welling and Dr. Basura. One is about the staging. Which do you prefer to use for jugulotympanic tumors? I've seen there is the FISH, there is the Jackson Glasgow scoring, but there's also a modified, I think, FISH and Sana scoring that does the A1, A2, B1, B2, C1, 2, 3D, D1, DE1. It's a more detailed grading system than the original FISH grading. So which one do you prefer for your patients, more so in regards to surgical implications?
I'll let Dr. Welling start. Go ahead, Brad. If you'd like.
I see these tumors rarely enough that I don't find classifying them that helpful. The reason I say that is just because I think anatomically with good imaging, we can describe where they go. And so even though I trained with Glasscock and Jackson, who had their system, and and Bruce Gantz, who was one of my instructors trained with fish, and they both talked about those systems. I, from a practical standpoint, don't really find that helpful. For example, for a Class A glomus tympanicum, where it's confined to the middle ear, it depends a little bit on whether or not you can see the circumference of the tumor in the middle ear through the tympanic membrane. If you can't, then your imaging will help you know how far down into the hypotympanum, like the case that you just showed. How far into the hypotympanum does that go? And can you approach this through a transcanal approach? If you can see the circumference of the tumor, I think you can. If you can't see the circumference of the whole tumor, then a transmastoid facial recess approach is better. So I think, frankly, it's nice just to really describe the extent of the tumor based on imaging rather than to classify it. People who see many of these may find the classification system useful, but I don't actually use either one of them. How about you, Dr. Becerra? You probably have a more sophisticated.
No, I agree with you, Brad. Honestly, I don't feel like the sometimes these tumors fit in a neat little box so cleanly with some of the descriptions. So I agree completely. It's usually describing it anatomically where it's extending to. So yeah, so I'm gonna answer your question. I really don't adhere to any particular one. Describe it in general terms and then where it's extending. Yeah, exactly.
And my second question is about imaging. In which cases, especially for the jugulotympanic tumors, would you go ahead and ask for an MRI? Because from her presentation, CT seems to be what's commonly done. When would you ask for an MRI? Given that you know it's within the ear and it's some bony space, so a CT temporal bone should be able to give you the bony extent of the tumor or erosions. Would you ever ask for an MR to assess extent of the tumor?
I do kind of like the idea of a CT arteriogram or a CT angiogram, just so you rule out other lesions that may be in the head and neck area. But from an anatomic standpoint, the CT is certainly most helpful to define the bony confines and to plan the surgical approach. So I wouldn't necessarily, if there are no other tumors and I can describe the tumor well on the CT scan, then I would not necessarily get an MRI. Now, if there are other neck masses and other tumors, then I think that it may be useful to get an MRI. But especially, I think that Allison had mentioned for following them long term, it's nice so you avoid the radiation load. And I think that makes good sense. If you're having one, you're just following. MRI imaging is fine, but for a glomus tympanicum, CT is much more helpful, I think.
Yeah, I agree completely. And many times, Amna, the patients are already coming to us with imaging that's already been done. So sometimes we're at the mercy of what they've had. And so I think the take home here is if you see a reddish pulsating mass behind the drum, number one, as Tribina said, do not biopsy it. Okay, that's job number one is don't touch. Number two, though, is you've got to get some kind of imaging below the middle ear, because you can't assume that's a glomus tympanicum, right? It could just be the tip of the iceberg. It could be a glomus jugulare that's blown up into the hypotympanum into the middle ear. So if they've had no imaging and I see that, I usually start with a CT, like a temporal bone, and as Dr. Welling mentioned, some kind of angiography. I like to look at the vessels. So CT angio of the head and neck and a CT temporal bone is always really good to start. And then honestly, the field is evolving. We've determined that certain genetic mutations will appear better on certain imaging modalities. So if people they test positive for a certain genetic abnormality, then some people have said dotatate scans or full body MRIs, maybe based on what is best seen for that particular tumor variant on the genetic testing. Obviously, genetic testing isn't available worldwide, and even in areas where it might be available, it can be expensive, and insurance may not cover that. So you still have to get some kind of imaging typically, but many people will base that off the serum metnephrines, and keep in mind that norepinephrines have a lot of false positives. there's certain foodstuffs, medications that can really falsely elevate the norepinephrine and give you a false impression that it's a secreting tumor. So the metnephrines are a bit more accurate in that regard to determine if it's secreting. So I would start with focal imaging, head and neck, vascular including, and then if they have positive serum metnephrines, then you have to probably broaden your gaze because then you have to make sure they don't have an occult pheochromocytoma or something else in the abdomen. But that's typically where I'd start.
And my last question, Allison, could you show us the last image of the ear? For that particular tumor, if this patient had gone ahead and opted for surgery, in my setting, we don't have laser. So how would you, the one before that, what would be your surgical plan? I only have cautery to my disposal.
Well, if it's a glomus tympanicum, you typically wouldn't necessarily need laser. You can have little microbipolars. Many of these, if it's favorable, you can go transcanal, lift the tympanomeatal flap, and then remove the tumor right off the promontory. It typically has a little blood supply coming off the promontory, and if you have a little microbipolar, you can safely cauterize that little feeder vessel and then just evacuate the tumor. So you wouldn't necessarily need a laser for that. Many times though, it's usually not that clean. Usually it's the tip of the iceberg and they've got a big jugulare below that. And so sometimes I've just debulked these out of the middle ear to alleviate pulsatility and symptoms of conductive hearing loss. And then you leave the tumor in the jugular foramen because presumably they have lower cranial nerve function intact. So that's a little bit of a different, potentially a different approach. You might have to, depends on the involvement. You might sometimes that may have to go post-auricular. You may have to open the mastoid. You may have to work through a facial recess, etc. But I don't necessarily think you need to have laser for a nice glomus almost a tympanicum. I mean, you can have a little microbipolar, should be fine.
I don't usually use a laser, even though it's available to us. I find the microbipolar is more likely to sort of contract the tumor down, make it a little more manageable, and a laser can actually perforate it and cause bleeding before you're ready. If you're going through the canal and you can see all the way around it, I don't often find that feeding vessel until after the tumor comes out, and then either bipolar it or put some adrenaline-soaked gel foam down on it. Through a extended facial recess approach, then I think the bipolar is sometimes helpful to kind of shrink the tumor down if you have a nice microbipolar. But I prefer bipolar to laser for these type of tumors.
Yes, and then my last question, I've seen a couple of these back home, and once the tumor is out, the eardrum that you have, especially if it was filling out the entire middle ear, looks very thin and stressed, like the quality of eardrum that you have left. Would you try to support that with maybe fascia or a graft, even if you don't see a visible tear? Because there are some of those where the eardrum, once you remove the drum of the tumor, it looks very thin and flimsy. Would you try to reinforce that with maybe a cartilage or even a fascia graft after you've taken out the tumor?
If the drum's intact, I don't. But sometimes if they've eroded into the drum or there's a small rent in it, I will put some fascia in to help. I don't usually use cartilage on these only because their eustachian tube function is usually normal, and I don't. I mean, you certainly could. I think it would be an adequate graft material if you had a perforation, but if the drum's intact, I usually don't. I usually just take the tumor out and see how it matures and heals up. If you were concerned that there might be a rent or it's really very floppy and you're worried about weakness of it, I don't think it would hurt to put a graft under there either. So I'm not sure. What do you think, Dr. Becerra?
Yeah, no, I agree. I mean, most of the time, I think I've been able to dissect the mucosal surface of the drum away from the tumor. And if many times that fibrous layer of the pars tensa is still there and it seems pretty hardy, I usually am able to successfully just lay the tip of the needle flat back down, and then that's done well. But I agree, if it looks, I think it's kind of a judgment call. You have to just kind of see how it looks intraoperatively. If it looks really tenuous and you worry it might get sucked in or could be prone to perforation, you could put a little small fascial graft, but I agree you wouldn't need to use cartilage right off the bat. Yeah. So kind of a judgment call, but I haven't really had to repair them. Sometimes the tumor's blown out the drum already, so my hand is kind of forced to remove some of that. So I'm forced to repair the drum. But if you catch them earlier, you can salvage the drum, and ideally wouldn't have to do a repair like that.
Okay, for me, I have one question. For us, most of our patients in our hospitals, especially the ones who have glomus jugularis, are sent for radiotherapy, but then they still end up having recurrence. So my question is, one, radiotherapy versus surgery, especially if you find the patients early enough, which one would be of better benefit? And two, when they have undergone radiotherapy, but they still have either resistance or the tumor is still growing, could there be a role for decompression? Sometimes our oncologists ask if you can do decompression surgery and then send for further radiotherapy after reducing the tumor burden.
Yeah, I guess to answer your question, Lillian, it would depend on how comfortable people feel resecting these tumors and what their cranial nerve function is. These are very radiosensitive tumors, so radiation is very effective, but obviously if you radiate the middle ear, you're going to get maybe delayed hearing loss. So I think a lot of the thinking is if the cranial nerves are intact, it's hard to justify removing, especially jugulares, because you're putting the lower cranials at risk, particularly if you don't do that on a regular basis. So I think the field has moved away from primary resection in the jugular foramen for those that have intact lower cranial nerves. So you can debulk. I mean, debulked a lot of these out of the middle ear and then left the residual in the jugular foramen and watched them. If it starts to grow, then you could radiate that residual, which is pretty effective. And then obviously, again, it just depends on the comfort level of the treating team. Do they feel comfortable removing this? Just as a side note, my new institution here, my very first case on faculty here was a 70-year-old physician from Kazakhstan who had a glomus jugulare. And
That's the other case I was going to present, but
yeah,
I didn't have time.
She had lower cranial nerves intact. Her hearing was compromised though, because the tumor had basically eroded part of her inner ear. So she really didn't have usable hearing, but her lower cranial nerves are all intact, facial nerve intact. I presented her at our skull-based board, assuming that my colleagues would just opt for radiation, particularly in a 70-year-old with coronary artery disease on anticoagulation. To my surprise, neurosurgery said, "No, we could take that out. Let's take that out." So my first case here, I did basically a fish procedure, fish A, but I did a fallopian bridge technique where I kept the facial nerve pulled on the fallopian bridge on the descending segment, just at the level of stylomastoid foramen. And then I dissected deep to that into the hypotympanum, took the mastoid tip off, took her canal wall down, oversewed her ear, did a fat graft. And my neurosurgical colleague, we removed the jugular foramen component, and she did great. She did great. Obviously, her hearing was already gone, but her facial nerve was intact. She had some brief, like kind of transient dysphagia that then recovered, and she's doing great. So you can see kind of there's some different, again, it comes down to levels of comfort. And so there's a lot of variables there, but fortunately these are radiosensitive tumors, so you can radiate them and have pretty good success with tumor control.
That sounds like a great patient to radiate to me. If I was on your tumor.
Oh, I know that, and that was my thought going into the tumor board presentation. I was shocked that one of my colleagues would want to operate on that, and I was like, okay.
A young neurosurgeon.
I was like, okay, all right.
The reason I wouldn't operate on that patient is because of the lower cranial nerves,
Right.
and so often 9, 10, 11 are affected by a glomus jugulare tumor removal, where radiation, even if you knock out the lower cranial nerves with radiation, it occurs over a year. It occurs slowly. It doesn't happen immediately. So they have a chance to sort of you know, they compensate both their vocal cord and their shoulder. When I was a fellow, we did, I think, 17 glomus jugulare tumors, and we were very aggressive about taking them out. But a lot of people had a lot of trouble with their spinal accessory nerve being out. They couldn't reach their hand up over their head, and 10th nerve problems and so forth. I think that, to a large extent, these do so well with radiation. I don't disagree that taking some of the middle ear mass out to get rid of the pulsatile tinnitus is a reasonable thing to do, but for the rest of it, I would think about radiation. Even for a younger person, I would. But for somebody who's anticoagulated and has 70 years old, I mean, I'd say that was a bold move, and I'm glad she did well.
Oh yeah. I developed basically some stress-induced cranial nerve neuropathies just from.
Someone also biopsied that lady. They biopsied the mass in her ear,
Yeah,
thinking it was a
right.
polyp, and then
Yeah.
she presented with like severe bleeding out of the ear.
Yeah, that's how she
was
presented to me.
anticoagulated. Yeah.
Yeah. Just for the record, I didn't biopsy that. I just want.
Yeah, it's somebody else. Somebody else.
I want to make that clear to the participating audience.
It wasn't Dr. Rollins.
Yeah, no.
It was not me.
Yeah.
Well,
exactly.
someone did.
Yeah. Yeah.
I've had a resident biopsy a glomus tumor, and all I had them was shout, a busy OPD, and I just had someone shouting for help, and I'm sure the resident would they would never touch a glomus again because the patient really bled, and we had to admit and transfuse and counsel the family about what's happening in the ear, and because they had violated like the capsule, we kept getting rebleeds over the next few days. So it was a bad lesson to learn for them, really.
Yeah. And luckily it wasn't like an aberrant carotid artery, right? Could it be?
It did bleed.
Oh
It
yeah.
Very much. Like I came from the room, I've seen patients in, and this lady is on the couch. She's bleeding. The resident has packed, but there is blood all over, and she's just shouting. So the whole room is in a fracas. Yeah. So.
Yeah. That's the main take home right there. Is don't touch. Yeah. So I'll ask one last question before we go. So what if you had a pulsating red mass in the middle ear and you got a CAT scan and the radiologist is like, oh, this patient is missing foramen spinosum. Would that help you with any thoughts?
It's an aberrant carotid artery.
Is it aberrant carotid?
Sorry.